Hello and welcome to Spinal Chat episode 5. My name is Dr. Ivan Stoev and I'm a board-certified neurosurgeon practicing in Nashville, Tennessee. Today's topic is going to be spinal stenosis, and I'm going to talk about both cervical and lumbar stenosis and some of the procedures that we do to alleviate that problem. Now, first of all, some people are born with congenitally short pedicles, which leads to a congenitally narrow spinal canal. This is an unfortunate thing because they are more predisposed to have problems later on in life. But aside from this congenital abnormality, for the average person, spinal stenosis can arise from a number of different things. One, when the discs degenerate, and that occurs as we get older, they tend to lose their elasticity, their thickness, and their sponginess, and they become a little firmer, a little flatter, and sort of lose some of their height. When that process occurs, they also tend to kind of expand out. And when that occurs, you can imagine how the disc can push into the spinal canal where the spinal cord is. Now, this is a model of the cervical spine, and we've used that in the previous videos. Just as a refresher, here's the spinal canal here in the middle where the spinal cord resides. And from the spinal cord, these little nerves exit to go to different parts of the arms. A stenosis is a descriptive term. It doesn't really convey a whole lot of information other than that there is simply narrowing of a space. Stenosis can be central, and this is where the central spinal canal is. That's where the spinal cord is. Or it can also be foraminal, and foramen is the name that we use to describe this opening between the vertebrae where the nerves are exiting out to go to the arms. Now, they all can manifest in different ways depending on the severity, the location, and how many levels are involved. But generally speaking, if you have central stenosis that is compressing the spinal cord, that can lead to a condition known as myelopathy. Now, myelopathy is a clinical diagnosis that basically means some sort of damage to the spinal cord. And it can manifest in many different ways. One of the ways is numbness, tingling, burning, weakness, loss of coordination, poor dexterity, difficulty walking, even spasticity or stiffness can occur. And eventually over time it can lead to contractures and pretty severe disability. The stenosis can occur from discs that are degenerated and are bulging into the spinal canal from the front, or from thickened ligaments that are pushing into the canal from the back. Also, it can result from joints that are degenerated and enlarged and swollen, such as when you have arthritis of your spine, for example. All of these elements can combine to cause narrowing of this spinal canal. Now, this is a fairly serious problem because there is no medication or no therapy that can enlarge that physical space. It's an anatomical problem of narrowing, and the only good way to treat that is with surgery to make more space for the spinal cord. Now, this is a particularly dangerous situation in the cervical spine because anything from the point of involvement down can be affected. As you go further down the spine, then there's less things that can be affected in the body because you're further down. I'm going to talk about the cervical spine first because I think that is kind of a little bit more important. And I want to discuss a couple of terms or mention some terms that pertain to the cervical spine. Now, we said cervical stenosis is the stenosis in the central canal where the spinal cord lives. Normally, around the spinal cord, there is some space, and that space is filled with fluid. It's cerebrospinal fluid. And that provides protection to the spinal cord. It allows it to kind of shift and move a little bit as we're moving our necks. If you get into a traumatic event, such a car accident, it provides a buffer cushion of protection for the spinal cord, dissipates some of the forces, and therefore protects the spinal cord. Now, patients who have severe stenosis do not have that protection. Their spinal cord is basically sandwiched between a disc in the front and ligaments in the back. So there's no fluid there, And if there is any kind of a traumatic event, they can sustain significant injury to the spinal cord. Now, this is something that I worry about as a neurosurgeon because spinal cord injury is very serious, and oftentimes the effects are permanent. And even with surgery after the fact, the chances of full recovery are pretty slim. And it kind of depends on the severity of injury. So we want to prevent that from happening. So if I see a patient who has significant stenosis and they have some symptoms associated with that, it is time to intervene. There's no sense of wasting time with conservative management or medications and things like that. Now, personally, myself and most surgeons that I know are not alarmed very much by pain. I know pain is a consideration for the patient that brings them to the office, but pain by itself is not that important in our mind because pain can be treated with medications and therapy and things like that. Stenosis, however, that is important because if we do not correct that, the significance of it can be very long-lasting and it can be devastating to the patient in the long term. So now that we know sort of the pathology here, how do we address it surgically? I want to mention one more thing. The term called myelopathy indicates this compression of the spinal cord, but there is another term called myelomalacia that actually signifies a visible injury to the spinal cord on an MRI scan. Once you see evidence of myelomalacia, you have to intervene, and you have to do it pretty quickly because we can see that the spinal cord has sustained damage already. We want to prevent that from continuing to occur. And also allow it some recovery as well. So how do we decide on what type of surgery to do? Well, there are a couple of things that play into that. This is the back of the cervical spine. If the patient has maintained the normal cervical shape, which is like the letter C curving back, then it's feasible to do surgery from the back. And there are a couple of different ways of doing that. Now, we make an incision in the middle of the spine. We can take a drill and cut off these bones here and just remove them. That unroofs the spinal canal and it opens the top of it. So now there's a lot more space for the spinal cord. This is called a cervical laminectomy procedure. This is a good procedure to open up the spinal canal. However, if there are a lot of levels involved, that could potentially cause instability of the spine because we are removing bone that is there for a reason. There are ligaments here that are attaching, that are causing it to remain stable. So one of the dangers of performing a very long laminectomy is that the spine can become unstable or it can start to curve forward, kind of fall forward, and this is not a good thing. Now, if we have to do a long segment of decompression, we may have to consider putting screws and rods in the spine to stabilize it and prevent it from curving, forward in the wrong direction. I'm going to talk about that fusion surgery in a different segment, in a separate video. There's also another procedure called cervical laminoplasty. The criteria for that are very similar. You still have to maintain that normal shape of your spine before you even start with the surgery. But instead of cutting the bones here completely and removing them, what we do is we take a drill and we basically run it along these bones on one side all the way through. So basically make a trough cut along here and take the drill and make a partial cut on the other side, but still have bone that is remaining in that place. Then we take these bones and we just flap them open a little bit like opening a door. It's called an open door laminoplasty. And then we put a couple of small titanium plates to kind of prop it so it doesn't go back down. And that allows for the spinal cord to have more space. The advantage of the laminoplasty is that it is not a fusion. You still preserve the mobility of your neck and you get the benefit of decompressing the spinal cord. Now, for cases where you have compression of any of these nerves here or foraminal stenosis, then we can do either a minimally invasive surgery where we just focus on the particular nerve that is a problem. We go in with a small incision and we just drill a little bit of bone over that nerve to open up the area of the nerve exiting. So that decompresses that particular nerve. Now, this is only done for just a few nerves because for each one of those, you have to make an incision and go down and address it. So not a good thing if you have all your nerves really compressed. That just won't work very well. If you have only one small area of stenosis, we can do this with a minimally invasive surgery where the incision is very small. We do it through a little tube with a microscope and open up this area. If you do a small decompression, you don't have to do a fusion. There are a lot of things that play into that decision making, but generally speaking, these are the general principles. Now, what happens if you have an abnormal shape of your neck? If the curvature of the neck is falling forward instead of back, like it's supposed to? Well, then decompressing from the back isn't going to work because the spinal cord is draped over bulging discs, and that continues to exert pressure on it and damage. So then we have to go from the front. And this is the procedure that I described in episode 3, where we go from the front, we remove the discs, we put little spacers, and we put a titanium plate and screws. The procedure is called anterior cervical discectomy and fusion. So you can look up that episode for a much more detailed description of that. So here's a model of the lumbar spine, very similar to the cervical. In essence, we have vertebrae, there's discs between them, and then you have facet joints in the back, and the nerves exiting through the neuroforamina going to different parts of the legs. In the central part here, we have the central canal. The difference here is that we do not have a spinal cord in the lumbar spine. The spinal cord stops between L1 and L2, so somewhere up here is the end of the spinal cord. The rest of the spinal canal is basically filled with floating nerves, and they just kind of travel down until they exit to go down to the legs. So when we do these procedures for the lumbar spine, we have a lot more space. You can take the nerves and can move them aside. You have a better working corridor, so we can do a lot more things, a lot safer as far as minimally invasive approaches, and there's a lot of different varieties of surgeries that we can do there. Similarly to the cervical spine, for stenosis in the lumbar spine, we can do a laminectomy where we remove these bones and take them out. And again, if you take too many of these, you have to supplement it with screws and rods to stabilize the spine. But for a couple of levels, it's okay, and that's not usually a problem. We can also go from the front through the belly and come from the front of the spine and remove the discs that way and put plates and screws and grafts and stuff like that as well. We can also go from the side. So going from the side like that, we can remove the discs, decompress the spinal canal, the nerves, stabilize it, and we can also go obliquely at an angle approximately like this. Now, I'm going to cover these surgeries in detail in future videos where I focus a little more time on each one of them and their different benefits and downsides. So, in summary, stenosis is a condition that is best treated with surgery because it's an anatomical constriction of the neural elements, such as the spinal cord, the nerves, or even the foramina as the nerves are coming out. Many different surgeries can be done. The approach really depends on the rest of the pathology, how many levels are involved, the severity of it, and sometimes surgeon's preference and comfort level. One thing I want to stress is some of these conditions can progress over time very slowly, and the onset of symptoms is kind of insidious, and people don't realize that it's happening until it's too late. I've seen patients come to the office with contractures of their arms. They can't feed themselves, and I wonder, how did it get so bad? Why did you wait until this point? And the answer invariably is that, well, it started off with numbness in my hands, then I was having trouble buttoning my shirt, I was dropping things with my hands, I couldn't feed myself, and then it progressed to the point of being in a wheelchair. So people don't pay attention to symptoms that are slowly progressing, rather than if you are in a car accident and all of a sudden you have these symptoms, obviously you're going to be in the emergency room getting this taken care of. So some of the challenges are to recognize when this is occurring and prevent that process from continuing to occur so people can have a good chance of recovering their function and their strength. Thank you very much for joining me today and spending your time with me. I appreciate your subscriptions and your comments below. Stay tuned for future videos. And as always, feel free to leave any comments below.